You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle. The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.
Hi, everyone, and welcome to another episode of the RC Executive Launch Podcast Series, Season 2. I'm your host, Praveen, and I'm super excited that you're all joining me here for this episode today. I'm super excited to welcome today a leader whose career uniquely bridges frontline clinical care, enterprise revenue cycle operations, and the responsible application of emerging technology in healthcare. Our guest is Keisha Downes, Vice President of Middle Revenue Cycle at Beth Israel Lahey Health, where she leads middle revenue cycle operations across a multi-hospital system. Her scope spans clinical documentation integrity, hospital and professional coding, health information management, and utilization management, functions that sit at the critical intersection of clinical quality, compliance, and financial performance. What makes Keisha's perspective especially compelling is that her path into revenue cycle leadership is deeply rooted in clinical practice. With more than 20 years of nursing experience, including critical care roles in neurosurgical ICU, trauma step-down, and interventional radiology, she understands healthcare from the bedside up. Over the past decade, she has translated that clinical insight into leading high-performing revenue cycle teams that strengthen documentation quality, reduce organizational risk, and consistently exceed performance targets. Before joining Beth Israel Lahey Health, Keisha served as Senior Director of Mid-Revenue Cycle at Tufts Medicine, where she led large-scale operational transformation and the centralization of middle revenue cycle functions. In her current role at Beth Israel Lahey Health, she has been directly involved in the successful implementation of AI applications within middle revenue cycle operations. Today, she partners closely with C-suite leadership on enterprise strategy and change management, and she serves on her health system's responsible AI use committee, helping guide ethical and compliant AI deployment. In addition to her operational leadership, Keisha is actively shaping the future of the profession. She is an adjunct professor at Purdue Global, regularly presents at national conferences, and is currently pursuing her doctorate of medical science at Northeastern University with a research focused on AI governance and middle revenue cycle applications. Today, we will talk about her journey from critical care nursing to system-wide revenue cycle transformation, how she thinks about aligning clinical excellence with financial integrity, what responsible AI adoption really looks like in practice, and the leadership principles that guide her work in complex health systems. I'm very excited for this conversation. Please join me in welcoming Keisha Downes. Keisha, welcome to the show, and thank you so much for joining us today.
Oh, thank you so much for having me. It's always interesting to hear all the things that I've been involved in from others. So thank you for sharing that.
Fantastic. Keisha, let's jump right into our first topic. Now, RCM and finance teams are inherently highly complicated. They're complex environments. And to add to the complexity, these teams also face a lot of pressure today from various quarters, starting from payer delays to staffing gaps, and patients complaining about lack of options for them, and on and on. The list goes on and on. How do you go about thinking about your top strategic priorities for your organization when you look ahead the next 12 months versus the next 3 years or 5 years?
Well, I think the most important thing is to allow data to drive what it is that we are trying to solve. So there's a lot of things that are out there. They're not plug and play for all these different facilities. So understanding what the needs and goals are within our system based off of that data is what's really helping to drive what should be on our, roadmap when it comes for this month, this year, or the next 3 to 5 years.
And you talked about data. Another related question when it comes to strategic priorities is organizations always bring a lot of interesting projects that contribute both to patient experience as well as to the ROI of the organization. But a leader at your level always has to make very tough choices, right? So maybe can you share an example from the last 1 to 2 years of where you had to say no to a really good initiative in favor of something that was much, much more critical?
Yeah, so I think, when we think about technology and AI type solutions, I know there's been opportunities to like build bots and have bots built RPA, and have that come in. But they weren't solving immediate needs. So when we're trying to prioritize where the truly the operational opportunities are, sometimes while things are nice to have, they're not necessarily going to help contribute to the digital transformation that we're trying to achieve. And sometimes we need some of those quick wins to be able to tap into versus the nice to have. So again, letting that data drive what we consider what's important for right now versus what we should be considering for future state.
That makes sense. And whenever we go to large events like HFMA, MGMA, and on, we hear a lot about some of the topics like patient financing, financial assistance, claim denials management, and on and on, in almost every one of these events, right? So where does something like a denial prevention or a patient financing or financial assistance fit into your strategic roadmap? When you think about it, every year versus specific years where the need could be higher. How do you think about that?
Yeah, so I think from my standpoint, how I can be more proactive with denial management is really top of mind. And does that mean people? Does that mean technology? Does that mean process improvement? I know the buzzwords currently are around how do we get technology and AI to help combat some of the volume that we're dealing with when it comes to denials. And a recent conversation that I had is, while there's a drive to try to be more proactive with denial management and not reactive, what we're finding is the volume is so overwhelming that we are just becoming reactive more quickly. So we're able to react to what the payers are saying and what we're getting back when it comes to denials in a more timely fashion. And we really want to try to get to that more optimal state where we can start having more prevention and be proactive with the volume of denials that we're receiving. So I think that's really top of mind for me when in current state.
Makes sense. And maybe a slight drill down question on that specific topic of denial prevention, because you brought up two interesting topics in your previous response. One, denial prevention, the difference between prevention versus reaction. How
Mhm.
do you, in fact, strike a balance, right? Because every year is going to be different. And it also depends on how the payers are changing things on their end. There could be changes in policy, changes in documentation requirements, and on and on. That is on one end of the spectrum. And on the other end of the spectrum, denials in itself has a wide spectrum of reasons as to why denials could happen, like credentialing or coding changes and on and on. So looking at this complete spectrum, A, how do you maintain that balance between proactive versus reactive? And B, how do you prioritize across these various areas within denial prevention in order to make sure that you not only serve the patients the right way, but maximize the ROI for your own organization?
Yeah, so and I think that's why I say we're becoming just reactive more timely because being able to stay on top of all of this policy changes and coding changes and rule variances definitely makes it more challenging to be more proactive. So I think what I'm trying to focus on, again, it comes down to that data, looking at what exactly we're being denied for. Is it medical necessity denials? Are we not having the code that we've contractually agreed with the payer that we would have appropriate for medical necessity? And why? Is there education opportunity with the clinician? Is there a coding opportunity? Is there technology that can help the clinician get the correct code that they need? Because, clinicians are not coders. And a lot of this is we lean into the clinician to select the correct ICD-10 code, and we have to find a way to give them the tools that they need so that they can align a little bit better with the skill set of a certified coder. So while that may not, I think we're past the state where we can have someone, a coder sitting next to a clinician and help them select the right code, but we can upload policies into our EMR. We can tap into different type of technologies, and we can provide pop-ups that can help almost act as if a coder to let the clinician know in real time, hey, you're missing your laterality. Hey, you can't use this family history code. You need to actually give me a diagnosis. And that helps, again, with the patient experience. They're not having to provide financial expectations of the patient that's above and beyond what would be covered from their insurance.
That makes sense. Keisha, great insights on prioritization and denial prevention specifically. With that, let's take a short break. When we come back, we are going to be diving deep into recent initiative that Keisha's team led and what challenges they're solving for. Please stay tuned.
This episode is brought to you by rchq.com. That's ARCEEHQ.com, the Agentic AI platform helping healthcare providers improve financial performance by simplifying patient financing and financial assistance. From faster approvals to fewer write-offs, RCHQ makes it easier for patients to pay and for providers to get paid. Learn more at rchq.com. As a reminder, guest views are their own and do not constitute endorsement.
Welcome back. Thanks for staying on. Let's dive right in. So, Keisha, as we mentioned before the break, I would love to dive into a recent initiative that you and your team led and what challenges you were solving for. Please take it away.
All right, so within the mid-revenue cycle, there's always a concern that there's documentation insufficiencies and coding opportunities. To be able to audit 100% of, we had almost 150,000 inpatient discharges last year that were eligible for CDI review. There's no way to review 100% of those encounters with the thoroughness that we can have a confidence that we're not leaving anything on the table. So I had to determine how we could approach that potential problem, which was being reported back to me when we're considering MedPAR data and how our peers are performing versus how we were performing. I needed something to help validate if there's truly opportunity. So what I was able to do was kind of twofold. One, build a team of subject matter experts that can kind of focus on the areas that we are high value, low volume, so that we can have those subject matter experts focus in on that. And then as an additional layer, we added a pre-bill AI tool. And what that pre-bill AI tool was able to scrub 100% of the encounters and then help understand, okay, is there a documentation opportunity? Let's get that to the CDI specialist so they can query, or is the documentation there, but there was just so much documentation that the coder missed it. Let's get that back in front of the coder so that they can capture that code.
Makes sense. And once you identified the challenge, you mentioned that you built an AI solution. Can you talk us through how did you go about selecting that particular solution, or was it built with a partner? Was it built internally? Maybe can you share your journey once you identified the challenge?
Yeah. So we went through a third-party vendor, and there's a lot of technology out there. So it was a matter of determining what type of technology we wanted to implement. So there's different types of technology. So there's technology where the vendor has their team help review and alleviate some of the burden from my team of having to review it. There's technology that the burden would be on my team and have to review all of the suggestions and then have an action. So it was more so just trying to understand where were we in current state and what did I feel would help not just find the opportunities, but also, have that feedback loop so that when we're finding those opportunities, we're getting that information back to the coders and the CDI specialists as education. So those don't continue to be opportunities.
Makes sense. Anytime a project of this scale gets started and while going through implementation, there are always surprises, right? There are pitfalls, surprises, or interesting lessons learned along the way. What did those look like? Maybe could you please share any unforeseen pitfalls or surprises or interesting lessons learned from the implementation?
Yeah, so I learned a big lesson. I learned to start small and not big, and not to put 100% faith into AI. AI at the end of the day is just math, and it's looking at the probability of an opportunity being available, and that probability is never 100%. You know, the machine learning is only can only do but so much. So leaning into the technology a little too much and providing too much faith into the AI tool was not a fault of the vendor. It wasn't a fault of my team. There truly was I should have started slow and really worked our way up. So there were some bumps along the way in the beginning, and ultimately had to react quickly and make some changes. And now it's like working exactly like I want it to work. It's a really great collaboration.
Makes sense. Overall, the project sounds very interesting. Some
Mhm,
lessons, and obviously, it has added value to your organization. Could you talk
mhm.
about what was the measurable impact, or what has been the measurable impact so far? And how did you think about tracking success at different stages of the project and towards the end of the project?
Yeah, so thankfully this is like dollars, right? So it's easy to track dollars. So tracking dollars, tracking our CMIs or our case mix index. I'm able to see that line in the sand pre this solution and then post the solution. I can see that positive impact that it's having. Um, that was also one of the things that helped me realize early on that there was an adjustment that was needed. So when I was monitoring those numbers, that CMI and the financial impact, it was able to alert me pretty early on that there was a change in path that needed to happen pretty quickly. So um, those numbers have been my North Star from implementation.
Fantastic. For our audience who are hearing this terminology for the first time, maybe could you talk about CMI, how you define it, how you use it to make decisions for denials?
So CMI is a fancy acronym, case mix index. And what it's looking at is the relative weight or the weight of a diagnosis related group. So every patient who is admitted to a hospital is assigned what we call a diagnosis related group. So their diagnosis, their procedures are grouped into a certain number. And then that DRG has a weight. So it may have a weight of 0.002. It can have a weight of 30. It can really vary. So we take that, and then there's an algorithm where we look at how many inpatients we've had discharged. We have our payer rates. So we look at how much we get paid from the different payers. And then from that, we get a number. So it lets us know what our reimbursement number, and then ultimately that CMI lets us know how acute our patients are, how sick our patients are. Because the idea is that the higher the relative weight, the higher the acuity, and ultimately the higher the reimbursement.
Gotcha. And just as a follow-up clarifying question, you mentioned for CMI, every patient is assigned a diagnosis group. Are you ever in a situation where patients have to jump across diagnosis groups, given that their complexity to care could vary during the course of a treatment?
100%. And that's why we have our clinical documentation teams reviewing the patient while they're still in-house, because that DRG can be fluid. So they can come in with the signs and symptom. And as the patient's acuity grows, that DRG could also change. Sometimes the documentation doesn't support. So that's why we have those CDI specialists and the coders reviewing in real time. And they can query the clinician to make sure that the documentation is accurately reflecting the care that's being provided.
Fantastic. Learned a lot, especially around CMI. Kesha, thank you so much.
Of
With that,
course.
we're going to take a short break. When we come back, we are going to talk to Kesha about how she and her team thinks about up and coming technologies like Agentic AI, AI in general, and on and on. Please stay tuned.
The RC Executive Lounge is proudly sponsored by rchq.com. That's ARCEEHQ.com, where Agentic AI is transforming how providers manage patient payments and financial aid. Providers using RCHQ are seeing more collections, less manual work, and greater access for patients in need. Visit rchq.com to learn more about the platform and schedule your personalized demo. As a reminder, Guest views are their own and do not constitute endorsement.
Welcome back. We are going to jump right into technology. So let's shift gears into technology. Keisha, what role do you see agentic AI playing in revenue cycle as you look at the next 12 months versus the next 3 to 5 years for your organization?
So I think that we're looking more at AI and technology that can not just suggest things, but that it actually acts. When you think of technology that pulls from discrete data fields and it'll provide information, the idea is as we get into more agentic type of AI tools, it can actually act. It can say, this is what the data is showing. Here is some potential outcomes that we should be considering. Like when we're thinking about routine cases, denial, pattern recognition, being able to act. So when I think of the payer information being loaded into the EMR, what we may get right now is an alert that says, hey, this may not be a covered diagnosis. When we're thinking agentic and being more action oriented, it may say the denial percentage is this much for this particular diagnosis. We should be considering X, Y, and Z, being more action oriented versus task.
Makes sense. And in your mind, are there areas where AI can truly shift the game? And I'm not talking about like minor incremental improvements. Normally, a technology of this scale tends to bring 5x to 10x step function improvements to new fields. So do you foresee agentic AI playing that role of step function improvements in the field of RCM?
I do. When we think about ambient scribes and how that's been able to, one, cut down the PJ time for our clinicians, but also provide more robust documentation, that's helping upstream make sure that the documentation is more optimized. That in turn makes sure that we are accurately reflecting the acuity of our patients. We are able to code to a higher level of specificity. And then if we're also able to put that piece into that says, hey, at the time of your order, this documentation or this code is not specified enough. Here's the probability of a denial. Again, we're moving into more of an action-based, allowing those clinicians to make those decisions in real time. And that's how we get to be more proactive with denial management and not reactive.
Makes sense. And outside of agentic AI, are there any other up and coming technologies that you and your team are actively exploring, either specifically for RCM or even across your whole organization?
So I can tell you, I love AI and tools within RCM, and I constantly have different type of vendors reach out to me to share what type of tools they have. So you would be amazed to know the tools that we have for coding, autonomous coding, where we can actually have encounters coded from documentation to claim without a coder having to be engaged. There's AI within the CDI space that's able to suggest documentation opportunities in real time, not just to the CDI specialist, but also to the clinician. When I'm thinking about utilization management, helping understand those interqual versus Milliman level of care opportunities. And then again, thinking about, okay, is this patient truly inpatient? Are they OBS? Are they or should they be outpatient or observation? And then what's the probability of this being denied? How is this aligning with the payer behaviors and payer policies that can help us make sure that we're getting the patient level the right way? So there's so many different tools that are out there. It ultimately comes down to, the bandwidth, IT bandwidth, your team's bandwidth, and how you're able to get these things implemented.
Maybe one related question to what you mentioned.
Mm-hmm.
In these kind of environments, with a lot of AI vendors and AI tools out there, bringing a lot of AI tools also means IT overhead, but there's also this problem of sprawling of tools such that like managing information flow across all these tools is complex, but also even for the teams, learning all these tools and making sure that they work coherently to get the outcome that is required for revenue cycle is also complex. How does your organization think about that?
So I think having some type of AI governance is so important. I sit on the AI responsible use committee. Above that, we have the AI governance committee. And I think that's where that kind of governance is overseeing what all is being implemented, making sure that we don't have things that are overlapping, things that are duplicative, and then also making sure that it meets the needs of our system. So, and we're also not just thinking about the technology and how it's being implemented. We're considering cybersecurity. How are we able to use this technology, but also keep our patients and their information safe? That's very top of mind and very important. So, how are we doing those things? So, I think having this multidisciplinary group come together. Our groups have not just RCM, but we also have clinical support. We have IT support, legal, compliance. There's all these folks who are coming together who are able to speak from their own personal or their own professional aspect of how we should be considering these tools.
Makes sense. And you mentioned that you are part of the committee that looks at governance, compliance, and all. Specifically, when you think about or AI tools and AI vendors, is there like a checklist of top 3 or 5 things that you look at? Patient information is definitely one part of HIPAA and all. Specifically within AI or for AI, what are the things that you look at from a compliance, regulatory, or even from a governance perspective?
So I think, the first question is always, what is the problem that we're trying to solve? Because again, there's so many tools out there. We don't want to implement something just to implement. How does it align with our goals? We have strategic goals that are organizational goals. How does this particular tool align with those goals? And then we also look at, maturity of the AI. What type of AI is it? AI is not just the blanket term that it used to be. We're able to speak to, is this NLP? Is it agentic? Is it machine learning? Is it deep learning? We can ask those type of questions. And we're also going even step further, asking, about governance from internally. How is there a black box? Are they able to explain kind of what is coming from this different technology? And where's the human in the loop piece? Are there reports? Is there oversight? Is there auditing? All these questions are very important to make sure that the tool is going to align with our goals.
That's perfect. One last question to close this segment before we move to the final segment, which is on leadership. Every RCM leader that we had talked to in this podcast series, they tend to look at one metric either every morning or once a week. Is there such a metric for Keisha? If so, what is that metric?
Oh boy. So every morning I am looking at my CFB, so my candidate for billing, because I want to understand if there's any barriers for getting these things coded and out the door. Especially with mid-revenue cycle, there's a lot of things that can hold up between HIM, UM, coding, CDI. I just want to make sure that there's nothing on my end that's holding these things up. So there's a report that goes out every single morning, and I'm scanning for my areas and my owning areas to make sure that we're not missing anything. And ultimately, what I'm looking at is how long has it been on this list? Do I need to support my leaders who are directly overseeing this list? What are the escalation needs that are needed? Is there a clinician that is out of town and their documentation needs to be signed? Are we looking at this encounter from a quality standpoint? Perhaps we're looking at a PSI or a patient safety indicator. Perhaps we're looking at a mortality encounter that we're trying to make sure we're accurately reflecting why the patient expired. There's so many different things that can contribute to why we want to hold up an account. I just want to make sure that we're not being a barrier to our AR goals.
That makes sense. A lot of amazing insights again. Thanks, Keisha. With that, let's take a short break. When we come back, we are going to be talking to Keisha about her thoughts on leadership, how she approaches leadership in a complex RCM environment, and in general, what is her leadership philosophy? Please stay tuned.
Today's episode is sponsored by rchq.com. That's ARCEEHQ.com. If you're looking to reduce friction in patient payments and increase access to financial assistance without overwhelming your revenue cycle team, RCHQ's Agentic AI platform might be exactly what you need. Head to rchq.com to learn more. As a reminder, guest views are their own and do not constitute endorsement.
Welcome back. Let's jump right in to the leadership segment of our podcast today. Keisha, change is hard, especially in a complex RCM environment. Change management is really tough. How do you build momentum for change across your teams? Especially, we talked about a major initiative in one of our previous segments just 10, 15 minutes ago. When you think about that kind of an initiative, how do you think about change management and using effective change management to permeate change across the organization?
So I think for me, the biggest thing that I live on is transparency. So I don't like my teams to not understand the why, the intent behind some of the decisions that are being made. And everyone wants to know, how do these decisions impact them? So I'm very transparent with that as well. If a decision means that we're going to have to rearrange or reconsider how an org structure is working, I'm very transparent about that. I always lead with data. So often of course, there's always data that's driving some of the decisions that are being made. I'm transparent with where the opportunities are, where the concerns are, and then why these decisions are being made. So I'm very transparent when it comes to any decisions that are being made and very open to receiving feedback.
Transparency is key. Great insight. Another related question. You've been operating at this level for a while. If you could give one piece of advice to another RCM leader or a CFO tackling similar challenges, what would it be?
I would say don't let the perfection be the enemy of good. A lot of times we feel this pressure that we're not allowed to make mistakes. There's this pressure that we have to be perfect. And as long as you are able to identify problems in real time, you're looked at more so from where you're able to adjust and adapt, not the, bad decisions that were made. And I think that's a perfect example of the implementation that I had, where it was not successful in the beginning. There were a lot of questions and concerns. But ultimately, because I stayed on top of it, we changed course in a timely manner. I'm not looked at as, there was a bad decision that was made. It's more so we were on top of it. We were able to change course, and now we have a really positive outcome.
I mean, at the end of the day, the final outcome was amazing. That any issues along the way is seen more as a glitch in the journey than
It's,
ruining the outcome. So that's again a very powerful insight, right? Like, don't focus on perfection.
yeah.
Last question for the day. Hopefully, there's a fun one. Is there a reason book, a podcast, a framework, could even be like an Amazon Prime video or a Netflix video series that you saw that has significantly influenced your leadership thinking or changed your leadership principles significantly?
So I'm going to sound like a nerd, but Harvard Business Review has like stories and a collection of books that they have out. So I'm actively reading this collection of books that they have, and it focuses on managing people, it focuses on strategy, change management, leadership, and then managing yourself. So I find myself actually quoting these books often. So I really feel like it's helping to contribute to my view when it comes to leadership, and how I also bring up leaders underneath me.
And if there is one specific concept or a principle that really, really resonated with you very deeply from any one of these books, maybe can you quote an example for us?
So there's one of the concepts within it, with leading people, is how do you tap into and keep employees energized that maybe they don't have experience enough to have a certain title or be assigned a certain responsibility, but they're eager, they're excited, and they really do want to contribute. There's ways for us to find, to be able to help feed that curiosity that these folks have, because these are really the ones that are going to end up being our future leaders. So, you don't have to have subject matter experts all the time. You don't have to have longevity all the time to invest in someone who's really excited about the mission and the goals that you're setting. So, I've learned that from one of the books.
Keisha, very powerful insights today. Thank you so much for joining us in the podcast today and sharing all these amazing insights. You're giving our listeners Plenty of takeaways from this episode. Thanks for joining us today.
Thanks for having me.
The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.